and I'll be talking on cognitive dysfunction in diabetes. Diabetes being a multifaceted metabolic disorder has transitioned to a complex condition with potential implications far beyond glycemic control. Every one of you sitting here will definitely agree with me. When you talk about the cognitive impairment, what does it mean? Deficits in memory, attention, language, and executive function. It represents a significant challenge to the affected individuals, their families, and healthcare providers. We talk about the pathophysiology, several potential pathways, vascular factors, oxidative stress, inflammation, insulin resistance, and microbial gut-brain axis. Everywhere today talking about the microbial gut-brain axis. If you look at the central nervous system, what are all the various factors which can contribute to the cognitive dysfunction? As I already said, the microangiopathy, macroangiopathy, hypoglycemia, hyperglycemia, glycemic variability, and poor or tight glycemic control all can lead to cognitive dysfunction. Who are the risk factors for a cognitive decline? Again, talking about both hypo and hyperglycemia, oxidative stress, and vascular complications of diabetes, mitochondrial dysfunction, aging, drug therapy, and obesity, lack of physical exercise, and neuroinflammation. All things, the insulin resistance from IRS1, PI3K, AKT, they can go in for the cognitive decline, and you can look at the formation of the amylin beta plaques and the p-tau based tangles. They are one of the pathological hallmarks of this disease. And you look at the diabetes, one hand have comorbidity and medication, on the other hand genetic predisposition, which the underlying mechanisms like atherosclerosis can cause a brain infarct, and microvascular disease which can cause an incidual ischemia and glucotoxicity, which can lead to advanced glycation products as well as oxidative stress. And again, looking at the insulin, there can be increased secretion of insulin. Again, there can be breakdown of amyloid. All can cause brain pathology. One is vascular, aging, and Alzheimer type, which can lead to dementia. So how many people develop cognitive dysfunction? Who will develop? What is the major mechanism? Is it preventable or delayed onset? Look at the genetic factors: ApoE gene, amyloid beta production, immune response in the brain, the TREM2, and HTARA1, vascular cognitive impairment. These are all the factors which are indicated in genetic factors. Here look at on the left hand side you can see PSEN mutation without ApoE mutation, and the right hand side you can see PSEN1 mutation with homozygous ApoE3 RN36S mutation. On the left hand side you can see that down you can see the amyloid burden, the tau burden, hypometabolism, hippocampal atrophy, everything is high. So the age of onset is quite young, 43 to 45. Here almost the dementia comes at the age of 49 to 50, and these are all the major the effects in similar to Alzheimer. On the other hand, whenever there is a mutation with the homozygous ApoE mutation, you can see the major one defect is the amyloid burden, and other things are less, so that the pathology, the age of onset is later. See, what is called NLPR3 inflosome. The chronic hyperglycemia can activate the NOD-like receptor protein 3 inflosome and induce the inflammatory cascade, resulting in cognitive dysfunction. Dear colleagues, kindly bear with him because this new topic, which a lot of research is on, and we are still trying to learn, and I have learned when started preparing for this topic. So, a lot of newer terminology and a lot of pathophysiology. See, this is how the NLPR3 acts, and when you look at when the ATP, the potassium enters, then the calcium enters. When the mitochondria create the reactive oxygen species, there can be a active NLRP3 and NLRP3. There is an interaction between there's a complex, inflosome complex, then leading to pro-caspase 1, and again there can be a lysosomal dysfunction, and there can be NFK beta, which can prime and cause all the inflammatory mediators like pro-interleukin 1b and pro-interleukin 18. So these are the various mechanisms of the neurodegenerative disorders. Again, looking at the oxidative stress, reactive oxygen species, and blood-brain barrier breakdown, and inflammatory cytokines, and apoptosomes, and mitochondrial damage. And this is what happens in diabetes. One is that hyperglycemia, which can cause glucose neurotoxicity, and advanced glycation products, which can cause NFKB1 and reactive oxygen species, which can cause vascular endothelial dysfunction, inflammation, oxidative stress, which can lead to impaired cerebral microvessels and neuronal death and cognitive dysfunction. On the other hand, look at the insulin dysregulation, can cause the ID reduction, and which can cause the tau phosphorylation, which can cause the neurofibrillary tangles. On the other hand, impaired insulin signaling can also lead to that amylin beta and amylin beta secretion clearance, thereby amyloid beta plaques are deposited. So do pathological findings. One, on the left hand side you can see the impaired cerebral microvasculation and neuronal death. On the other hand, formation of neurofibrillary tangles and amyloid plaques both can cause cognitive dysfunction. This is gut-brain axis also. Okay, so there is an alteration in the gut-brain axis, which can also basically, how does gut connect to the brain? It is mainly through the vagus nerve as well as the neurotransmitters. Whenever there is an alteration in the gut-brain axis, this can also cause lead to the cognitive dysfunction. And what are the specific manifestations? When looking at the pathophysiology, hyperglycemia in the brain, insulin resistance, cerebrovascular disease, other mechanisms like mitochondrial dysfunction, neuronal dysregulation. And on the other hand, what are the clinical manifestations? One, attention and concentration deficits, memory impairment, and executive function dysregulation, and visuospatial ability decline and language dysfunction. So, what is the role of these drugs? Flavonoids and omega-3. They can have a beneficial effect on the vascular dysfunction in terms of endothelial impairment and atherosclerosis. Again, looking at the metabolic impairments in type 2 diabetes, mainly at the amyloid metabolism. And here also the flavonoids can be useful. Again, at the inflammation also, flavonoids and the omega-3 fatty acid can be useful. Do the probiotics have any role in this? Yes. And look at there's an interconnection between the pathways to the neurodegenerative diseases like mitochondrial dysfunction, protein misfolding, and microbial metabolites. And on the other hand, you can look at the microbiome targeted therapeutic intervention using lactobacillus can also be helpful to ameliorate this one. And what is the mTOR and citrulline targets? Whenever there's an overnutrition, physical inactivity, and a chronic anabolic state, what happens? There's increased amino acid and glucose flex and impaired insulin signaling, which can cause an mTOR overexpression. Unrestricted mTOR hyperactivation can cause endothelial dysfunction. On the other hand, if you are able to suppress the mTOR activation by drugs like SGLT2 and GLP1, there can be improvement in the endothelial dysfunction, reduce the oxidative stress, and reduce inflammation. So this is one of the important therapeutic option, and this is the basic mechanism how the neuronal dysfunctional dementia occurs. I already explained in detail most of the time. There's an inflammation, impaired metabolic hormonal system, and hyperinsulinemia and brain insulin resistance, which causes a downregulation of insulin transporter at the blood-brain barrier, and insulin receptor lost by the amyloid beta oligomer, abnormal insulin signaling, reduced clearance of the amyloid beta plaques. And again, the microvascular disease can cause morphological changes, and the amyloid beta deposition and tau hyperphosphorylations are very, very important things in the mitochondrial dysfunction, which can lead to the neuronal dysfunction and dementia. Again, looking at the hypoglycemia, the neuronal cell death, platelet aggregation, and fibrinogen formation, receptor damage can lead to, again, neuronal dysfunction and dementia. Again, looking at the inflammation also can be responsible, and impaired nigrostriatal dopamine function and nigrostriatal dopamine depletion can also lead to the neuronal dysfunction. The role of SGLT2 inhibitors and GLP1 analogs, basically these two can act on, apart from the reducing the blood glucose level, it can reduce the body weight, blood pressure, there can cause a reduction in the endothelial dysfunction, increase nitric oxide bioavailability, and reduction in the systemic inflammation and oxidative stress, and reduction in the mTOR signaling, and reduction in the ROS and sympathetic neuronal hormonal pathway, and reduction in the fatty acid oxidation, increased glucose oxidation, and reduction in the amyloid beta plaque aggregation, and reduction in the tau hyperphosphorylation. And by all these mechanisms, these drugs seems to be promising in addressing the cognitive impairment in diabetes. This is fingolimod. The sphingosine kinase actually it's a modulator of the receptor, SNP receptor modulator, which can also help you, which will make the lymphocytes are available in lesser numbers so that there's less inflammation and leading to the lesser cognitive dysfunction. This is the mTOR inhibitors, rapamycin analogs like sirolimus and everolimus, and we have ApoE targets, reducing the ApoE4 levels using antisense oligonucleotides. These are short synthetic sequences of DNA or RNA that can bind to and degrade specific mRNA molecules, effectively silencing the gene. One. Second, the CRISP or Cas9 gene editing. This technique allows for precise editing of DNA sequences, potentially enabling the knockout of the ApoE4 allele or its conversion to a less harmful isoform like an ApoE3. Other gene silencing methods are also into vogue. And dear friends, I just tried to take you through what is cognitive dysfunction, what are the various possible mechanisms of cognitive dysfunction. We are talking about the mTOR overexpression today, and we are talking about the tau phosphorylation or hyperphosphorylation, and what are all the different therapeutic modalities. Many things are under research, and right now the drugs are not approved for the management, but lot of research is on. And so cognitive dysfunction in diabetes is a neglected entity. Unless you look for, you cannot find it. See, a basic understanding of physiology is essential. Glycemic control is the key, along with the addressing various metabolic insults, and precision medicine with the SGLT2 inhibitors and GLP analogs may be helpful. Don't think I am talking this talk on behalf of GLP-1 and SGLT data, because some data are available and the mechanisms also explained, and lot of newer advanced therapies are in the research, and right now they have a limited role. In the time to come, we will get more answers. Thank you very much.